안녕하십니까. 고울담치과병원 치과보철과 김학구입니다.
Hello, this is Kim Hak-kyu from the Course Dental Clinic. Today we're going to look at diagnosis and treatment of edentulous patients. Some patients are fully edentulous or some have some teeth remaining but needs to be extracted and replaced with implant. There are things to be considered, but I think in summary, 9 things should be considered. First, you have to think about form and volume that's residual bone is remaining, and how much the bone has been resolved, and what is in status of the opposite teeth, and also interocclusal space, and also abutment status, and arch form, and rib support is also important. And because there is a patient host factor, what is the oral hygiene and how is the plaque accumulation and caries. And if patient is fully edentulous, you might not have to worry about that. But if it's especially some teeth remaining, these things need to be considered. But I think more importantly, you have to think about financial consideration of the patient age, whether he or she has denture experience and desire for treatment, as well as for surgeon, difficult surgery, and also technique of the surgeon should also be taken into consideration. Now, if the bone is not really much resolved and bone quality is okay, full fixed implant restoration might be the first choice. This is more than 67 years old, but with the full fixed implant, it's close to natural teeth, and people always seems to satisfied. They say they are using very well, and through the regular checkup, and if the perio is well maintained, there's not much work to do, and long term, it's good maintained. So overall, full fix, if there's not much of resorption, but if it's full fix, you have to think about number of implants. Now on the maxilla side, if you place 9, 3, 1, 3, or 5, 4, 7, 5, 6, 7 could be consideration, but for number 4, if it's really resolved and because of the implant angle, it touches the root, then maybe 3, 3, and then you could use cantilever. And also not much bone on the anterior, and 3-3 bridge is not really recommended, and up to 4, 2 of 8 could be bound together. So in terms of these sections, or number 3 bone is okay, but here there's a lot of resorption. 4-2 can be bound together, and 5-7 at the back. So in the past, when you did full fix, the implant service or the implant was not really trusted, and because the implant was weak, you have to bind everything together, and 8 to 10, create it as one muddy. And the full mouth was really stressful in the past, but in terms of implant surface, a lot of things have been improved. The prostheses, difficulty-wise, and for future repair art, it's better to separate anterior posterior, and it's better to have a sectioned prosthesis. So there are more cases that we could think, but I think in the offline lecture we can talk more about these. Now, if the bone is good, then fixed might be option, but it's not always the case. The patient has a good bone. So what if in the posterior there's a bone resorption a lot? And in case of sinus augmentation, the bones are reliable, hence it takes a lot of time, but fixed might be will be good option. But in the buccolingual bone resorption a lot, so you cannot really have a lot of bone grafting. So crossbite needs to be considered, and the plane rather than strength, a splint is more important because shear ratio becomes bigger. So shear ratio, the load on the joint might be increased. So with the multiple and binding the implant will be better. But if they don't want to surgery and if it's difficult, then removal at the back and in the front maybe implant. So residual bone there's not much left, but in case of that, with the sinus left, we can place implant, and through the implant, the teeth that were shaking and not bad becomes actually better. through the implant. But that was maxillar. But what about mandible? It's a bit different. It's very hard to do bone grafting for lower part. So if there's a lot of bone resorption, then here vertical augment or block bone graft for implants, it's really challenging and there's a lot of difficulty. So in the past, with overdenture, you used to do removables, but nowadays we have a lot of different short implant with good surface. So if there is at least some bones left, then like this, look at the distance to nerve and using the short implant, we can place implant. And in doing short implants, compared to short, the crown height becomes longer. So if possible, splint would be better option. However, beyond that, if the posterior has a lot of resorption, it even touches the nerve, then inevitably, and if the anterior is very absorbed, then implant overdenture. But if there is not anterior resorption that much, then maybe a class RPD could be option. So this type of case. Now here, nerves are coming down, and if you see the impression tongue base and the border is not really visible with a lot of resorption. So it's not indication for fixed approach. So two implants at the lower, and of course you could use the bar type, but if the aged person and you consider arch form, it's sometimes just making it stay in place might be good for the comfort of the patient. So bone resorption determines a lot of distance. So for if it's like this, we can do fixed, but if it's 30 millimeters or more resorption, and if there's a lot of lowering on the posterior sides, the other thing can be considered. So like this on the upper part, height porcelain on the lower part, pink porcelain could be used to have fixed. However, vertical resorption is high, then the horizontal resorption would also be high. So if you see the resting position without denture, see here, you have also a lot of deepness here, and you don't see lips here anymore. So if you fix would not be an option, because wax denture shows you have to do this to have lip support. So if you say fixed and give height, it's very hard to stay clean. So overdenture would be better option. And with overdenture, you have to think about vertical bone resorption. So 12/8 and locator type and bar type, 70 millimeter of the spade needs to be secured. Otherwise, you have to cut the bone for design purposes. And actually, if the distance is shorter, then like this, the magnet overdenture, but with the load being pushed, there's a fracture and he has to come to the dentist more often. However, there's resorption a lot on the back side, but on the anterior side, even after extraction, the space is small. Then, rather than overdenture, fixed surveyed bridge would reduce coming to the dentist and becomes more comfortable to use. So, not many cases where there's only anterior resorption, but if it's too close to nasal cavity, then implant class RPD, or on the posterior side, there's a bit lowering on the buccal side and overcompensation needs to be done, then implant overdenture might be an option. So if there's a lot of resorption like this, not many cases, but even if there's a resorption, then if there's no critical structure here, so sometimes you use fixed approach. But for a patient, they might not be able to stay clean and clasp pipe and then plan next to it might be an option. But here, there's a lot load in the center. So, it's not a design that's been recommended. If there's some teeth remaining, then extraction needs to be decided yes or no. Now, it was a case referred to me, and the denture at the lower side, there was pain. On the upper side, the denture was shaking, and there was a lot of uncomfort. And so for this, strategically, extraction and removable on both sides, matching, would have been more convenient for the patient as well as for the dentist. And actually, of the full edentulous patient, if there's a residual teeth, which teeth to extract it to remain and preserve, you have to really think about. So you have to discuss about the prognosis of natural teeth. Sometimes you only think about whether it's shaking or not, but if you have a perio treatment or the root canal treatment, you have to think about restorability. If it cannot be restored and if we extracted, and if there's no periodontal support, you don't know, cannot guarantee long-term prognosis. And based on this, the doctor needs to recommend best economic option and best treatment plan, and combine that with the patient desire. You have to offer and recommend the patient the best treatment plan. So you have to also see the opposing teeth. Sometimes here it's Edentulous and the single denture case, then the lower side will be weak and the upper side will be strong. So there could be pain. And there is it wants implant, but the bite has been distorted and there's deep bite and there's no space here. So when you consult with the patient, maybe a vertical dimension needs to be heightened, and you have to strategically approach that. After implant, you might not even be able to do prostheses. So you have to think about VD. So denture was okay, but it was broken, and here as a cross bite, this was touching on the lower side and this was touching on the upper part. So using cotton, I made him train and ask him to open it, and the optimal level, if this is the occlusal plane for this type of teeth, is too high, so it needs to be taken out, and it was too low, so it needs to be adjusted, and based on the implant treatment plan needs to be determined. So occlusal load of force here, it doesn't look good, but with overdenture, less than 2 years, the jaw was shaking and the teeth were all worn and framework was even broken. So in this case, using fixed to make a vertical dimension secure, there will be problems. So for this patient also, there's a lot of bone resorption and could not even use lower denture, but with the 2 implant and locator top, but on the upper side, he wanted also new denture. So I didn't want to extract teeth, but you could see their secondary case and bone level is also low. So RPD with the teeth remaining, the teeth prognosis would not be good. So it's much better to extract the tooth and make it all clean, and then full denture and overdenture on the lower side. Then even after a few years, it can stay clean and well maintained. So occlusal force, looking at the opposing teeth, is the determinant, and whether to do natural dentition or removable denture. A lot of different things like this needs to be considered. Just making it based on number of implants, there could be much bigger complications. So if it's removable upper part, removable on the lower part, and fixed, and milled bar that we used to use in terms of oval denture, it's a fully supporting implant. So for the teeth, it's artificial teeth, dentures. However, it's fixed. The load is like fixed. So milled bar, if there's wear, there could be fracture there. So there could be a lot of different problems. Arch form should also be considered. And whether it's full fixed or fixed hybrid over denture, arch form needs to be considered. And in case of full fixed arch form, on the anterior, it determines how many implants you will have. And for V-shape, here, if you don't place implant, but only 2 and create an section here, then when there's a load, these 2 implants gets a lot of load. So V-shape becomes bigger, arch form becomes bigger, and the occlusal force is increased. But if it's U-shape, then implant without having 4, about just with 3, the load is reduced. Hence, depending on arch pull, implant position and numbers should also be considered. Now, if in case of fixed type, this is more important. Here, 4 and its length, not double. Cantilever can go in, and for U-shape arch form here, looking at that, not 6 but actually shorter. Hence, maximum wise, this they say double from here, but if you have longer cantilever, then there's a lot of load put in, and then there will be bone resorption. But if it can hold, the framework can be broken, or it doesn't broke, but screw becomes loose. That kind of problems could exist. Hence, if the arch form makes difficult, then here maybe angled, tilted placement, then cantilever volume can be considered. So when you do overdenture, you might say it's not a problem, but for solid type, it's not really a problem. However, bar type, then we need space for clips. So for V-shaped, if you do here, tongue, there is no space. So you have to bend it like this. Then implant pretending a position becomes longer, so bar will be broken. So you put it on the front side, the clip becomes smaller, or sometimes you cannot use clips. So actually when you design bar tie, you have to see what arch form it is. Besides that, rib support should also be considered. Resorbed bones, vertical or horizontal side is seen, but bite in resting position, this area, lips, how much it has been reduced. For young people, it's okay. As you get older, muscles are no longer become weaker. So food retention sometimes happens here. So they might say removal was much more convenient. But it's inevitable because on the upper side, if there's an anterior side, if there's bone resorption, it comes here. For the lower anterior side, resorption comes here. So if in the normal bite, actually it changes class. So for this case, it was case 3. However, here it was protruding, and the existing denture, and it used to be crossbite, but it's edge bite, and it was protruding. The teeth was protruding. So we didn't want to use denture and could not keep it clean. So like this, looking at overall status, we could create a probe ear tie, although it seems very protruded. So with the rib support secure, you consider soft tissue here. The food can, we train the patient, so there will be no food retention. So when there's no flange in fixed prosthesis, the implant, if it's wrong, it's very hard to correct them later on. So for this patient, it was referred to me, or used fixed at other plant, but implant actually really was damaged at whole, and was elderly patient, and denture would have been better, but he wanted implant. But the bone, there's a resorption, there's no on the sinus side, but actually provisional denture, if it's made, then there should be a bit of rib support. Then even if with the fixed and graft, if you create a shape using provisional denture, you have to make an assessment and consult with the patient. Hence, if there's no rib support, then when you create overdenture, this is another hospital's case, but on the upper side, 4 was put in an overdenture, but implant there was always pain, and here there was fracture. And I do believe for this patient, it was really low denture compared to what he needed. But with the VD coming down, class 3 becomes class 1 as you open the mouth, and lower denture looks very bad, but with appropriate denture, mastication much better, and lip-wise becomes more comfortable, and mastication took less strength. So considering lip support, you look at bone resorption level, but in the maxillomandibular relations, you have to consider the appropriate VD also. And also, unless it's fully edentulous, when you think about extraction, the host factor is important. If the patient had multiple caries and the teeth are, there's a lot of caries and a lot of swelling, and it cannot be saved, And just because it's not shaking, you are not extracting, that's not it. If there is a caries, and for elderly patient, if there's a xerostomia, and in the cervical, there's a lot of caries, then strategically, for this teeth, they will not stay longer, so recommending implant might be better. And through plaque accumulation, after taking all the teeth out, the oral situation sometimes gets much better, and poor hygiene needs to be corrected. With the implant, you should change your way. It took time to do implants, so brush your teeth, and make sure to train the patient to keep the teeth clean. And I feel that patient needs and financial consideration are also very important. This was 39 years old patient, and this was 54-year-old patient. And although we joke around, money, yes, is important. Full fix would be good for this patient, but didn't have the financial means. So 2 and full denture on the upper side. But 54 patient, full fixed, but became more comfortable with this. So previous case, if this fixed would be better, but again, due to financial situation, overdenture was used. 80-year-old patient, but after taking out the teeth on the upper side, I said about the denture, she refused. So we had 2 implants on both sides, and using IPD, satisfied the denture was not shaking and could chew very well. So depending on patient needs and financial consideration, after diagnosis, how you do the treatment plan will be very much effective. On the lower side, this was in other dental clinic in early 2000, came to me in 2009. There's a lot of resorption sinus side, lowering sinus side. There were a lot of implants here. But using this bar denture was put in. But it's not really clean, and there's a lot of fracture like this. And teeth is wearing too much and could not really bite very strong. So did not want denture anymore. So I said it takes a long time, but it's possible. So it took a long time, but I did sinus graft, and with this full fixed implant was done. So denture, when I checked, there was fracture, there was a lot of repair work, but here every 6 months taking x-ray, doing cleansing, and maintenance was well done. So the quality of life was very much improved. Another thing, the patient's expectation should also be checked. Patient comes to me and says, I used to use denture very well, but it's shaking, so I wanted new denture. But I looked at the existing denture, and it was this one. So corners denture, it's good to use, but if the abutments start to break, there's a lot of problems. For this patient, it's open here, and teeth is holding in, and no clasp is what he wanted. But on the maxillar side, all teeth needs to be extracted. So after extraction, denture without implants, then used to use full palatals. So you have to persuade the patient. And maxillar, if the patient wants this, it will be challenging with the denture because you cannot do open palate with few placement. So full fixed, if it takes longer, because there is the teeth at the front, so there'll be not much resorption. So with overdenture, the bulging would be too big. So on the maxillar, full fixed, and on the mandible, we can have similar in design. So overdenture type by removing few implants and teeth would be good. So maintenance needs to be thought about. Some say these two are maintenance, good for maintenance, but I think it all depends on oral hygiene. So you have to educate the patient. And in terms of complication and repair complication, there is more for the removal type. But removal, it's easier to repair. But fixed type, it might be more costly, although there might be less problems. So what the patient preference, what the doctor decided, and patient finance and maintenance needs to be considered for the decision making of the doctors. So we look at the different options, and using that, what kind of prosthesis types are recommended to patient can be determined. And this is my last slide. So implant and in the natural teeth, what is the difference in implant? You have to determine the implant position for the patient. For the natural teeth, there's natural teeth, somehow the position is determined. But for implant, you have to determine the position. So the important thing is what the patient wants and what kind of prosthesis you're going to have finally. So with the patient desire and with the anatomy, whether you're going to do remove fixed, and based on that, you have patient treatment options. So what is always important is before you begin the project or treatment, before doing treatment plan, if it's full Edentulous case, the end result should always already be in your head, and clearly explain that to the patient. And with that clear direction in your mind, you explain to the patient, and then you will have successful result on your hand. So today we looked at diagnosis treatment plan for Edentulous patient. It was rather short lecture, but in the offline lecture, we can look at more cases. Thank you for your attention.